Everyone. It is 11:01, and we are going to drag our feet for a few minutes while everybody deals with their tech and their computers and trying to get on. So, at the top of well, first of all, in the chat, are kind of the rules for today. The most important one, which is the hardest one for me to follow, is we're going to not answer Q&A during the class because we tend to run out of time if we do that. So we're putting them to the end. Now, in this Zoom, there's a Q&A place that you put the questions in. Oh, I don't see it. Kate, does it normally show on the screen?
It's at the bottom. You have to hit more and then Q&A.
More. Okay, maybe that's why they're having trouble seeing it. Okay, so actually, Kate, would you put that in the instructions of the chat? Because if you don't click on more, the Q&A doesn't become visual.
Yes.
Yeah, people might not know about that. Okay, so when you have questions to ask, and please ask all the questions you have, that's fine, but put them in the Q&A. We'll gather them all up till the end of class. If you put them in the big chat, then they get buried and lost. And so it's hard for us to find them all. So we're still waiting. We've got lots of people coming in. So we're going to give it another couple of minutes for everybody to find their coffee and find their tech. And let's see, okay. Kate, do you know if I put a question in the Q&A, can everybody see all the questions in Q&A?
No, they have to be approved by me. So if
Got it.
once they're answered live, once I hit that, then they can see them once they're answered.
Okay. All right. So guys, any questions that you've got, we're going to answer them at the very end. Lynn, I see your question. Give Kate a call. She can help you with that. All right. I'm looking to see if we've got people that are struggling with their tech to get in. It's 11:03. We're just going to give a few more minutes for everybody to find their way in. Okay. Just so you know, guys, we don't need your OPPG number on the chat screen. And I know people are in the habit of putting it there, but that's not where Kate uses it from. Questions will come at the very end. Sharon's with us today. Good. Sharon with Ages is with us here. Okay. All right. It's 11:04. Let's do one more minute of folks that are trying to get in or so. So meanwhile, we'll start introductions. Good morning, everyone. My name is Teresa Barton, and I am connected to the peer group as the liaison for the peer group, and then also a liaison for other aged programs. And I'm here as a 30-year experienced professional guardian who's not actively practicing guardianship anymore, but I'm doing lots of mentoring. With us today, Tracy, you want to introduce yourself?
I am Tracy O'Neill Spencer, Client Benefit Specialist for Aged, and we have a benefits team here at Aged, which is Denise Campbell, and I'll let her introduce herself in a moment, and then Rose Carter. And I actually, if you guys are on the peer group, you know I work for Teresa for 4 years, and I've been with Aged for 9 years now. So doing benefit stuff, Medicare, well, when I work for Teresa, Medicare, Medicaid, and all the things benefits for the wards.
And one of the things you guys should definitely take away from this is if you're struggling with your Medicaid application, with your access, with any of that stuff, Tracy and Denise are phenomenal resources. And you can just call them or email them and say, hey, I am struck on whatever problem. And they have lots of helpful information for you. So that's what they're here for. That's why Aged supports the Guardians, because you guys have the toughest job in the world. There's other folks on here today besides Guardians, but that's the majority. All right, we are at 11:05 and we're still probably, think we just about got everybody. So I think we're going to get started. I don't think, since everybody's been here for a couple times now, I don't think we have to do a bunch more homework. Just a reminder, don't put your questions in the chat, put them on Q&A. If you don't know where to find Q&A, at the bottom of your screen on the far right-hand side, there's a circle with 3 dots and it says more. You click on that and it'll pop up Q&A in a box with a question mark on your screen so that you now have access to that. And you can put any questions in there you want. Questions in chat, become a struggle because we're running up and down the humongous chat of, of 160, 70 people. It's real hard to find them. So please put all your questions in Q&A. We will do them at the end. So this 4-part series came around because every day in the peer group and every day at Aged, folks are asking questions about benefits, struggling with understanding how all these benefits work and what do they all mean and why do they have 7 different names and all these difficulties. And Tracy and Denise and I worked on this slide for a long time, trying to find the right amount of information to not overwhelm you, but get you clear on what we got to do. So I think we're ready to go. Tracy, is there any other housekeeping we need to do, or are we good?
Actually, I just wanted to introduce Denise. Denise Campbell is joined us 4 years ago, Denise?
No, 2020.
2020.
Oh, okay. 6 years ago. Sorry. Time flies. But Denise came from Senior Resource Alliance. So she was dealing with the home and community-based services for Senior Resource Alliance. And she's going to be talking a little bit about home and community-based services a little bit later on. So if we're ready to get started, I will get started. Today we're going to specifically be talking about home and community-based services, long-term care. And we're, of course, the long-term care is institutional care program, HCBS, a home and community-based services waiver. We're going to talk about the wait list, how the services for Medicaid are handled on long-term care, which is the statewide Medicaid managed care program, and that is composed of the MMA, which is a managed medical assistance plan, the long-term care plan, and dental plans. We're going to go over some of the notices of case actions, or the NOCAs, and just touch on VA aid and attendance because a lot of people aren't aware that that even exists. So the long-term care programs, hospice, ICP, home and community-based services waivers, and HCBS waivers are actually, there are 4 waivers that fall under HCBS, and that is the familial dysautonomia waiver, iBudget, model waiver, and then the one we're going to concentrate on today, which is the long-term care. And people call it something different. Most people just refer to it as HCBS, but like I said, HCBS is different waivers, not just the long-term care. So we're not going to get into in depth about iBudget, but I just wanted to touch on this because a lot of guardians have younger wards or people that have developmental and intellectual disabilities, and that's handled through iBudget and APD, which is the Agency for Persons with Disabilities, which supports people with developmental disabilities, including autism, cerebral palsy, Down syndrome, intellectual disabilities, etc. And in order to join the program, you must live in Florida, be at least 3 years of age, and diagnosed with a developmental disability that occurred before the age of 18.
And I want to say something.
And all of that stuff.
Sorry, Tracy. I want to say something about autism. For those of you all who don't know Claudia, who works with us, Claudia is the mom of a developmentally disabled child herself, and she works with people all over the state dealing with this. Autism has become kind of like the disease of the day, meaning that everybody is getting that diagnosis, and APD is becoming less and less willing to acknowledge that they meet the criteria if they have autism in and of itself as a diagnosis. You have to get a lot more proof and a lot more reason for APD to accept someone with autism. It used to be that autism, just honestly, that diagnosis was enough. And now it's becoming things like they want a functional IQ. They want you just can't say autism. The doctor can't just say that, it's more. And this is going to probably get tougher with the sort of huge amount of kids, young people that got diagnosed with autism, but not with the specifics of why they meet the criteria for HPD benefits. So just be aware, if all you have as a diagnosis or a ward or a client is autism, that's likely to not be enough, just so you'll know. All right, keep going.
Okay. And really, I just wanted you guys to know that they need, you have somebody, a ward that is developmentally disabled or has any of those diseases, then they need to go through APD for home and community-based services. And you can submit an application through them. I put up the website and the phone number, or you can just search it and it will come up and tell you how. There are several different places where it'll tell you how to apply through APD. So moving on to long-term care, that is for individuals in their home or the community or in an assisted living facility. They must meet the nursing home level of care, and that is difficulty ambulating, eating, dressing, doing personal hygiene, toileting, or IADLs, like financial management, medication management, preparing meals, doing basic housework. They must be 65 or older, blind or disabled between 18 and 64. And that HCBS waiver comes with full Medicaid. If a person is at an ALF, they are responsible for paying room and board. So HCBS does not cover all the cost of them being at the facility. If they're in an ALF, it just covers the assistive services, that medication management, somebody preparing meals for them, that type of thing. And then the Medicaid, full Medicaid covers the medical need. There's limited funding and there is a wait list. And we cannot express that enough, that they have to get on the wait list in order to qualify for home community-based services waiver.
So Kimberly's asking, this is a tech issue. Kimberly's asking if we can make the slides bigger than the speakers. I don't know that we have that ability. Kimberly, if you've got the chat window, if you close that, that will make things bigger. I don't know of anything else we can do.
At the top, there is a view button. You can change the view. And if you mess around,
Kimberly, try to change your view up at the top where it says view. See if that'll do. Yeah, it says you can drag the screens as well. Okay, so Kimberly, you gotta, I think, try your own to get it to work better for you. All right, sorry about that.
Okay, just wanted to mention, if somebody is on the wait list for home and community-based services, they may qualify for medical Medicaid through DCF. So they need the medical coverage. And I am going to actually let Denise talk about the wait list. Denise?
Morning, everybody.
Morning.
Can you hear me?
We can.
Yeah.
Okay, I'm trying some new Bluetooth headphones, so bear with me. So the home and community-based service wait list, they are done by the Florida Area Agency on Aging offices, and Senior Resource Alliance is the one for this area. So what you would do is call them, ask to be put on the wait list, ask for your ward to be put on the wait list. You will speak to an information or referral specialist who will take some information down from you, and that person is going to schedule with a Medicaid counselor. So there's different sections of Senior Resource Alliance, and of course all of those. So once you get that interview, they have a document called the 701S, which you can find on the Department of Elder Affairs website. They will ask you a series of questions about your ward. Can they do this? Can they do that? Like, for example, can they dress themselves? Can they bathe themselves? If not, are they using a walker? Are they using a shower chair? Do they have a wheelchair? Do they have special utensils for eating? Because that's even a DME kind of thing. But they will ask you all those questions. It usually takes about an hour, hour and a half, depending. And they do at each place, they have a translation service if you need it. Because I actually had a person that I screened for the wait list that spoke Mandarin. So we actually had to call the transfer. Yeah, it was interesting. We had to call the translator service and get somebody who spoke Mandarin. So it was kind of interesting listening to the person as I was asking questions, and they would ask them in Mandarin. So it was so they do have a lot of information and
Denise,
and resources.
Denise, I want to ask a question about that part. You talk about
Right.
having the interview, and in a guardianship environment, we often have a struggle because the interview, we've got 3 or 4 players. We might have the caregiver at the house, we have the ward at the house, we have the guardian, and the problem is with that interview, what are your best suggestions so that the interview, number one, the interview takes place when we're there? Because otherwise, if the ward starts saying, oh, I'm perfectly fine, I don't need anything, that's what will happen. What are the like helpful suggestions you can have when we're in a guardianship environment and the interview?
Yeah, you have to make sure that the ward is not answering, because you're right. A lot of them will say, well, I don't need help. I can do that. I can do this. But then you have to, the interviewer should know, I said should know, to ask more probing questions. Okay, so you said you can do this, but can you take a bath by yourself? Can you get in the shower? Do you have anything that you use, a shower chair or whatever? But my suggestion would be to have the guardian on the call with the ward. So because the guardian should know.
Is it okay to have the caregiver too? Because they're the ones actually, I mean, will they allow that, do you think?
Yes.
Okay.
Yes. I've actually helped somebody here do an interview because she was too nervous to do it by herself.
Okay.
So you have to give permission to speak to that person, of course.
Okay.
Because SRAs, they're run through the Department of Elder Affairs, and they have their regulations they have to follow.
Okay.
So once you are interviewed and you get all that information in, they will give you a priority score. So what they're supposed to do is send a letter. I'm not sure if they still do that or not, but because they don't tell you right then and there what it is. At least I didn't when I was there. But the only people getting off the wait list right now are 5s. So if you do an interview and you come up with a 3 or 4, you are put on the wait list. That's it. The 5s, those people will be getting off the wait list hopefully within the next month. So say we did the interview today and you scored a 5. Well, you would not get off the wait list until March because it's a month later. You have to wait till the first of the month when the funding becomes available through the Department of Elder Affairs. So basically, like the next bullet says, you wait. So you wait for funding. The funds are released once a month, like I said. And then, but when they give you your score, if you get a 5, they will send you a 3008 form, which is a medical form for your doctor to fill out ahead of time, which makes it a lot easier because I've seen so many of those get rejected because they're not filled out right. They can't have 2 different ink pens, for example, 2 different writings.
What?
They all have to be, we had some rejected because somebody wrote it and then they gave it to somebody else to fill it out or check or whatever. Yeah, it's very specific because we did training with the CARES people.
Okay.
At Department of Elder Affairs, they're very, very strict on those forms.
Okay.
And you make sure that you have a medication list attached with that form or it will be rejected. So it's a lot, but so like on the bottom it says based on priority score, rank of 5. Now the only other ones that will beat the 5s basically are those that come from the APS people. which is the ones that they're referred to the APS as being, what's the word?
Adult
Mine's
Protective
going blank.
Services.
Oh, yeah.
Thank you.
It's
Yes.
APS.
I had a senior moment. Yeah, adult protective services, because I used to do some of those. And as soon as that came through, bang, they got off the wait list. Those are the top priorities because they're in the most need of help, basically. So then once the person is released from the wait list, the 3008, again, like I said, has to be done. And then once the 3008 is accepted by CARES, CARES will then go out and do an in-person assessment to see if it matches what, and normally it doesn't, because it's hard to do it over the phone what's going on, but the CARES person goes in, and most likely I would suggest to have the caregiver and the guardian there as well, so they can see what's going on.
Yeah, because the problem
then,
is, the ward will say, I'm fine in the interview. And
right,
you have to be able to kind of show that, although I know she's saying that, you have to be able to show this is what the caregiver's doing for her every day. She's not really fine.
Yeah. And with that, the caregiver doing stuff for her, but is it all the time? Right. Is she always there? She's not, right? I mean, it's who's going to be there 24/7 to help somebody except in a nursing home.
Right.
So that's another important thing when you're doing the interview, because a lot of people think that, oh my God, she's going to be taken away. They're going to put her in a nursing home. No. Most of the problem is with the caregiver. It's so much stress on them. Because we had a lot of caregivers. It was a lot of stress on them, especially when you're dealing with someone with dementia, because it's so hard to take care of that person. But you have to make sure you tell the truth on those. I'm not always there, or even at an ALF. Is there somebody there? Right away? Might not be, depending on the staff or whatever, how many people they have. So once the 3008, like I said, in CARES assessment is done, they will send the level of care to the Senior Resource Alliance. So what you want to do is apply for Medicaid then, and that is determined by the Department of Children and Families. And do not, like it says on the bottom, file an application for home and community-based services until the 3008 form has been successfully completed. Because you're just wasting your time and the person's going to get denied.
Yeah, that we just recently had a 3008 go back and forth between CARES and actually Senior Resource Alliance 4 times. One time the date was not on the bottom. The doctor didn't put his initials where he should have, or whatever. So it's important that is filled out and complete, is submitted to CARES for them to schedule their assessment before you even apply with DCF. So once you are able to, actually, here we go. I just wanted to show you what the 3008 form looks like. And I don't have the form with me right now, but if you can actually download this so you have a better view of what it is. There are asterisks on certain places here, and all of those, make sure that all of those are completely filled in. The required spots are filled in. So this is on the bottom. The 2515 form, which is the level of care, that goes up to DCF. So important for you guys to know there are different processes. It's not just filing that application with DCF. This process for the medical approval, which is done through the Area Agency on Aging and CARES, is important. If this is not done correctly, or for some reason the 3008 doesn't get back to the Area Agency on Aging in order for them to submit the packet to CARES, and the level of care is never done, that person will be denied by DCF. So once, like Denise said, once the Area Agency on Aging sees that report from CARES that they have done their assessment, and they've received that 3008 form and the packet from the Area Agency on Aging, they've scheduled their assessment, they've done their assessment, they do their report, and then the Area Agency on Aging is able to fill out the 2515 form and send it over to DCF. That's like the final check for their approval of the application for HCBS. If they do not have the 2515 form from the Area Agency on Aging, the application with DCF will not be approved.
Right. You have 6 months from the month you were released from the wait list to get all this stuff done. After that, you're done. You have to go do the whole interview process
Back
again
on the wait list.
and be placed back on the wait list.
So Denise,
So it's very important that you,
they hold your spot for those whole 6 months?
yes,
Okay.
you have 6 months to do that. And if you don't get it done, then, so my suggestion would get that 3008 first, get that done ASAP once the person is released. Because that takes the longest depending on the doctor's office, because some don't want to fill them out. We had some that were charging their patients to fill out the forms, which I think is ridiculous.
A lot of doctors
that's what would happen.
do that. Yeah, a lot of them do that now. But once you apply for Medicaid, you fill out the application for Medicaid with DCF. DCF just does the financial eligibility determination. That's all. That's what they do for most programs. They just do the financial determination. You can do the application online, as we suggest. You can do a paper application, or you can go to one of the community partner sites and do the application, or mail it in. Again, we talked about this last time. Documents you need for the application, the income documents from all sources, bank and investment statements, and they want the 3 most current months of statements. They're always looking at the current month. Like, they don't want the 1099 from last year. They don't care about last year. They can access that information. They want the current information. You need the cash value for any life insurance policies that are whole life policies. If it's a term policy and you have it listed, they still want to see the policy so that they can prove that it's term. A burial contract, and it should be an irrevocable designation, which means you cannot cash it in. Because all DCF is looking at is really the finances. They want to know if you have anything that you can get money for before they approve you for Medicaid, really. So once approved for the waiver, you have to select a long-term care plan. And actually now they are just auto selecting them for you. Whichever plan is in the queue is who you're assigned to. So long-term care plans are through the statewide Medicaid managed care program. That's how Medicaid is handled for actually for the state of Florida for most things. This managed care, private companies, and just about everybody that's on Medicaid will have one of these plans. The program has 3 components, which is the managed medical assistance plan, a long-term care plan, or a dental plan. And the MMA covers the medical, preventive services, behavioral therapy, pharmacy, transportation services. That's the medical piece of it. And then the long-term care plan covers the payment to the nursing facility, whether that person is on ICP in a skilled nursing facility, or the payment to the assisted living facility, or if they are coordinating services in the home, then they they cover the payments for those services as well. And with that comes the dental plan. Right now, there are just 2 plans for Florida, and they cover preventative and therapeutic services. Although I just found out that they do cover some dentures and that type of thing. If somebody is on long-term care, they are in an ALF, they are at home, or they are in a skilled nursing facility, they have what's called a comprehensive plan that includes all 3 of them. Because if you're just on full Medicaid, then you would just have the MMA, the Managed Medical Assistance Plan. You would just have that. And there are some instances where people will just have the long-term care plan. But if you are in, you are in a long-term care situation, then you would have all 3. And all of the plans are required to have minimum covered services. They all have to cover the same thing, basically. But some of the plans have different expanded benefits, which may be beneficial to the ward. Like some of them I know will cover, give a stipend for over-the-counter medications. They'll pay for chiropractic, that type of thing. And there are specialty plans, important if you have a ward that has one of these things like HIV/AIDS, if they have a serious mental illness, a child that has a chronic condition, or someone that has aged out of foster care. That's child welfare. There are specific plans for specialty plans for them. And the difference in the specialty plan is that say they have schizophrenia. The regular MMA would just allow for, say they're taking a certain medication and their limit on that medication, mental health medication, is 30 pills a month. The specialty plan would allow for them to have 90 or whatever it is that would meet their needs, or additional therapies. So it's important if somebody does have one of those conditions and they qualify for a specialty plan, that they are on that specialty plan so all of their needs can be met. The plans vary by region, and here's the map of new regions. In case you didn't know, they've gone to letters instead of the numbers, and they went from 11 to 9 regions. For Florida, the MMA and long-term care plans are provided by Aetna, Florida Community Care, Humana, Molina, Simply, the Community Care Plan, not to be confused with Florida Community Care Plan. Sunshine Health and United Healthcare is part of this as well. So the long-term care benefits that everybody has to cover are things like adult companion care, assistive care, homemaking, physical therapy, respite care, meal delivery. So they are required every plan is required to cover all of those things. And for the long-term care plans, if someone is in an assisted living facility, Medicaid doesn't cover the full cost of them. And unfortunately, I've heard a lot of stories from people, administrators, or I don't know what they call them, sales counselors at facilities, telling people, oh, just apply for Medicaid, it'll cover everything. It does not. It only pays up to, I think it's now up to $1,800, between $1,000 and $1,800 towards the care at the facility. And what each plan pays depends on the plan. And not all facilities, assisted living facilities, accept Medicaid. So you have to find out if they accept Medicaid and which plan, long-term care plan, they are contracted with. They're not required to be contracted with all of them. And some of them are just contracted with one or two that they know are going to pay them timely and as much as possible.
And as a guardian,
The patient pay.
Sorry, Tracy. As a guardian, what often we use the decision of what, when we would get the facility, get everything worked out, really, to us, it didn't end up mattering which program, which provider, because we want the one that the facility is the happiest with, that pays the quickest, that is the most responsive. And that's kind of a moving target. Sometimes the facility will say, oh, well, this program is fantastic, or this one doesn't pay our bill on time. So we would often ask the facility directly, which one of the programs you're contracted with, 3 of them, which one is working the best? And that's the direction we went. And that's why.
Yeah, I don't think that they're allowed to tell you, oh, you have to sign up with this plan, but just ask them which plan, like Teresa said, which plan is better for you. Or a lot of them too have gone down to just, yes, a lot of them have gone down to just 1 or 2 plans that they accept. And if your ward is auto-enrolled in, say, Simply, and the assisted living facility that they're in does not accept Simply, then you just have to change the plan. And I want to mention too that if someone is approved for home and community-based services, say the month of February, the plan does not start, the long-term care plan does not start until the following month. So it's not immediately, if they're approved on the 15th, that their services start on the 15th. It's not until the 1st of that next month. So, and at a long-term care facility or an assisted living facility, the patient does pay the room and board. And that's important to ask when you're placing someone in an assisted living facility, is what their room and board rate is. So the MMA plan, the Managed Medical Assistance benefits, these are the standard benefits. And remember, everybody that's on Medicaid would get one of these MMA plans. It's not just someone that's on long-term care. So that's why they have things like birth center and midwife clinic. But it does pay for vaccinations and medical supplies, and you see their nursing facility, dialysis, transportation, and prescribed drugs. And I've heard several people that have wards in an assisted living facility, the facility has told them that they need a separate Part D plan. The MMA portion of their long-term care, comprehensive long-term care plan, does cover prescription drugs. So you don't need to pay for a separate Part D plan. That is covered under the MMA benefits. And the dental plans, and I just put this up for you to see, there aren't a lot of dental services for adults, and a lot of it is prior authorization. Right now, there are just 2 plans, DentaQuest and Liberty Dental, that for the state of Florida that cover this. So if somebody is over the age of 21, they have dental exams covered, x-rays, dentures, extractions, but I know that most of that requires prior authorization. And they also will pay for sedation, which is really necessary for a lot of the wards I know that have developmental disabilities or, say, autism. It's important for them to be sedated.
Or significant dementia, it's very difficult. So from a planning point of view, as a guardian, dental care in any institutional setting has almost always been a challenge. So one of the decisions you're making, for example, if you go into a pooled trust sooner, one of the reasons you do that is to have resources available to buy dental services that you can control. You can't control these dental services very well. And many times we've had clients in ALFs, nursing home, group home, that we wanted to choose the dentist. We wanted to choose the oral surgeon. We wanted to choose the periodontal appoint doctor because they were really good with folks who are having a hard time sitting in the chair. So one of the advantages and reasons that you choose a pooled trust is to have some money sitting in a bucket that you can buy private pay services for, that you can actually control and have some quality that you want. So I tell this story because one time I was in a Medicaid dentist's office with the client holding the equipment together as this dentist is working on her teeth because it's a Medicaid dentist. He's the only one in the county. And the office was so dirty that I just about had a heart attack. So having good quality dental care in any kind of institutional environment is tricky. So I often, with these cases, if we've got the resources, if we have money in a pooled trust, I don't care what Medicaid is offering. We go to the dentist we like, we trust, who works well with our clients, and the transportation and the caregiver. It's a lot of expense for sure, but it's also better services. So just as an awareness, you don't have to use the Medicaid dentist if you have financial ability to find private services. Just some thinking.
And I just wanted to mention, if you have somebody that is in a skilled nursing facility in a SNF, this dental plan that's offered is not the dental care that is provided at the facility where they come in, like ARIA or whatever. This is not that dental plan.
Yeah, those are
like
confusing.
I said, they're just two providers for the dental plans, and you have to go out to these dentists. And when I worked for Teresa, trying to get an appointment you're looking at months down the line. So if somebody is in need of dental services, then you need to quickly make those dental appointments. So you'll be in the queue. So once you do file an application with DCF, you should receive a notice of case action. We call them NOCAs. So if you have a trust with us and we ever call you, me or Denise or Rose ever call you and say we need the NOCA, that's what we're talking about. We want the current notice of case action. If the application's pending, then you'll get a notice of case action that looks like the one here on the screen that says we need the following documents. We need, for us, we submit the trust documents, the income documents, the bank statements, etc. Review the notice of case action, all of those things. If they send you forms, make sure to send those forms back. If they send them, they want them. They're not going to approve it without having those forms that they sent you signed. Review the NOCA. You can upload the documents, which is, of course, what we recommend. Uploading them because they go directly into that person's file at DCF. Make sure if you upload documents, save the confirmations. There's a way that you can print to PDF to save the confirmation proof that you uploaded that document. Because for some reason, things that you send to DCF oftentimes get sent into space. And if you have to argue with them or request a fair hearing, then you'll have proof that, yes, I indeed did upload these documents to them. If you're faxing the document, make sure you put the name and case number on each page. We do recommend that for anytime you're uploading the document as well. And make sure you save those fax confirmations as well. The next we're looking at an example of a notice of case action that has a UMED on the top, and the bottom is a spousal allowance. And so if you look at the notice of case action, they don't detail when they have done an allowance, and I'll talk about the UMED in a second. When they've done an allowance, they don't give you the math to show you what they've done. If you notice that the amount on the top less than 160, this is for somebody that's in a skilled nursing facility. Their patient responsibility is $160 a month that they get to keep. The rest of their gross income is supposed to go to the facility. But if you do the math, it doesn't match up. So the math shows that the amount that they should be paying is $1,054. But on the bottom, it's $854. So there is some allowance that DCF is giving, and it is for actually for a dental plan. And that is, they're allowing $199 to be retained by the patient or the resident so that they can pay for the dental plan. And these are the facility plans that I'm talking about. Now they include dental, vision, hearing, podiatry. The ones that I am aware of are ARIA, Excel Health, Florida Preventive Dental Solutions, and Sheridan. And they are contracted through the facility. So they'll either send you a letter or they'll ask you, do you want to sign up for this? And the company, ARIA or Excel, whoever, submits the paperwork to DCF for them to approve this, to lower the patient responsibility, to allow them to take that $199.36 and pay ARIA directly or Florida Preventive directly. And you should not be paying the dental plan will send you a bill pretty much right away as they get them signed up, but you should not be paying it until DCF has approved it and you know their patient responsibility has been lowered. The bottom is an example of a NOCA for a spousal allowance, and spousal allowance is if you have a person that is, say, a wife that's living in the home and the husband is in the skilled nursing facility, and she needs his income to help pay those household bills, then they will, DCF will allow, and they have to approve this, they will allow some of his money to be diverted to her, the community spouse, to help pay those bills in the community. And then if you have somebody that is, say one is in a skilled nursing facility and one is in an assisted living facility, and some of that money needs to be diverted to pay her room and board rate at the facility, they can do a spousal allowance for that. But this $1,472 does become income for her. So if she's on Medicaid on waiver, then that would become income for her. But this is one of the few cases where they actually put the math because you have to know how much to divert to the community spouse.
And one of the problems with NOCAs across the board is how often they're wrong or missing information entirely or the wrong Medicaid program. It's often. It's not occasionally, it's often.
Yes. And for example, both of these NOCAs, examples of NOCAs are for somebody that's on HCBS waiver, long-term care, but they look very different. And oftentimes, the most often, we see they put the $160 personal needs allowance for someone that is in an ALF, and that actually applies to someone that is in a skilled nursing facility. So just know that they can look different and they are very confusing. Sometimes we get these, and I've been doing this quite a while. Denise has been doing this quite a while, and we look at them and what are they doing? What are they talking about? And we have to investigate a little bit further. So it's not you. It's never consistent. Everybody does things a little bit differently, which shouldn't happen, but unfortunately it does. So getting back to UMed, and some people have heard about UMeds, some people have not heard about UMeds. A UMED is an uncovered medical expense deduction. DCF has to approve this. It is a credit received for out-of-pocket medical expenses incurred when the individual is eligible for coverage in a nursing home. Excuse me. And it reduces the patient responsibility to the facility. And that allows them, the patient, to pay for that expense. Medicaid doesn't pay the bill. So a lot of times people think, oh, when are they going to pay this? No, they're relying on you to pay that bill with the money you're saving, not paying the facility. Allowable expenses include health insurance costs. So if somebody is in a skilled nursing facility and they are paying for a supplement, which happens to be one of the really good plans, like an F plan, and they go out to see their physician, it might be worth them keeping that plan, but they're paying $300 a month for that plan. You can submit that premium cost with the application, and DCF will deduct that. Say it's $300, they'll deduct that $300 from the patient responsibility to the facility to allow you or the ward to pay that premium directly. That goes for dental services, hearing and vision supplies and services, and I believe either if you have a hearing plan, vision plan through the facility, same thing. Or if you have a plan separately, then it would be the same thing. Therapy services, in addition to what the MMA would cover, if they are taking certain over-the-counter medications or have to supplement their adult diapers or nutritional supplies, then you can submit that those costs as well. And they also pay for, important, nursing facility costs, like back balance, but the back balance has to be for 3 months prior to them applying for Medicaid. And they cannot be within a transfer of asset penalty period. And transfer of asset penalty would be if they have sold a house and given their kids $50,000, $100,000, whatever, they would incur a penalty for transferring that money.
So in the guardianship world, you often get a case that someone is in a nursing home. Medicaid couldn't be accomplished because their direct deposit was going into the Social Security was going into direct deposit. They were over asset with their checking account, so they ended up, accumulating medical bills all over the place. I've always struggled understanding as a guardian how much time and effort and energy I'm supposed to put into getting all these bills paid. So making sure that you understand how UMED works can sometimes help, because if you're getting bills from these providers, you can tell them, apply for UMED. Now, Tracy, who can apply for UMED? Who's able to? Only the providers or the guardian, or who all can apply for it?
Anybody doing an application can apply for a UMED. It's just you need to put it on the application when you're doing the application, or when you're doing a recert, or say you have somebody that's already on Medicaid and they get you didn't know they had these bills, and you get these bills and they have a recert coming up. You can just apply, or I actually would just submit it as a change. And see if you don't ask, you don't get. Okay, so I would, as soon as you get that bill, then submit a change application and see if they will do a UMED. Okay. But I just wanted to note too that if somebody has a UMED, it is possible for them to have a zero patient responsibility. But just because they have a zero patient responsibility, if they are paying, if they owe the facility, say $30,000, and their patient responsibility is 0, they still need to be paying on that back bill. So you may not have a current patient responsibility, but you need to be paying that back bill until that is paid off, because DCF will not keep extending it if you're not paying it. And it is possible sometimes to get them to extend it if you're not able to pay that bill off. It was a huge bill. But again, it should be just for the 3 months prior to the month of the application. So for HCBS, it's important for you guys when you get the person, the ward is assigned to that comprehensive long-term care plan, which is the long-term care and the MMA. Actually, the card should be coming to you if you have your mailing address listed. Otherwise, it might be going to the facility. So it's important that you find out who the facility will know who the long-term care plan is. If they're in a skilled nursing facility or an ALF, they will know because they've got to have somebody pay them. So they'll know. They probably have that card on file.
So Tracy, when you say your address, meaning from the Medicaid application or from where? Where do they find the address from?
Yes.
Okay.
Yeah, we discussed that last time, to make sure that you put your mailing address down. And if you were assigned as the guardian for somebody that has existing Medicaid, I talked about this last week. Please create a profile for them and put your address as the mailing address so that they will send the notices to you. Because once someone is approved through DCF, the long-term care plan, the MMA plan, that's not handled through DCF. That is handled by ACA. And the information that DCF had doesn't necessarily transfer to, or it doesn't transfer to ACA. So your guardianship papers and all that information that they have about you, that you submitted when you filled out that application, does not transfer to the Agency for Healthcare Administration. You have to provide them with that information. Again, the long-term care plan, you will have to provide them with your guardianship documents and anything else that they need in order to talk to you. They have to approve it, just like DCF has to approve it. And unfortunately, there are several agencies that you probably will have to go through providing documents to over and over again. But as a guardian, unfortunately, you should know that's the game. You have to give it to everybody. Another hint is when applying for HCBS, make sure that 3008 form is filled out completely. All such sections that are required need to be filled out. And I was speaking to someone at one of the ADRC down south. The sections Y and E are the sections that are forgotten most often. So make sure you check that 3008 form. Make sure the medication list is from the chart and it is printed, the chart from the doctor's office, that it is printed. It is not a handwritten note or a post-it that you just submit with them. That does not work for CARES. It does not work for the Area Agency on Aging. You will get, once somebody's assigned to a comprehensive long-term care plan, then you will get the information in addition to the card. You will get information of handbook. If they don't provide a handbook, go online and look it up. All the handbooks are online. All the formularies for the prescription drugs are online. Everything is available online. Read that plan handbook because that'll tell you what's covered, what's not. If they're not getting therapy services, you can look in the handbook and see, oh, that should be covered, and know that they shouldn't have to pay out of pocket for that or whatever, but know what the coverage is for the plan that they were assigned to.
So each coverage has its own individual handbook, like whether it's Humana.
Each plan, right. Yep. Humana has their own, Aetna has their own. Each one has their own handbook for the Medicaid uh, plans. And there's a different one for long-term care. There's a different one for the medical, for the MMA. So you should know what, just read them or have them on, hand, or know how to access them at least, so you can go look up that information. And you can submit a UMED on the paper application in section G, and that's a picture of it. Or when you get to the application, if you're doing it online, there's a section, the expenses section, and add the medical expenses. There are a couple different places where you can add it. If it's a skilled nursing facility bill, you can add it as out-of-pocket medical or additional medical. If it's hearing aids, additional medical. If they have a Medicare supplement or a dental plan they're paying for, add that under health insurance. And on the right is the list of all the different things that you can add under out-of-pocket medical. So really the important thing is if you're submitting bills that need to be paid for a ward and they are in a skilled nursing facility and you need a UMED, put it on there somewhere. And you will have to provide them with proof. So you need a premium invoice or letter or some invoice of some type. You can't just put it down because they will ask you for it. And remember, if they are under long-term care, that is the biggest outlay of expense for DCF is long-term care. Nursing home bills are roughly $10,000. Assisted living, they're paying between $1,000 and $1,800 to the assisted living facilities. So they're paying a lot of money. They want proof. They don't just take your word for it. And no, a bank statement showing it on the bank statement is not proof for them. They want proof from the source. And Denise is shaking her head because we often get people that say, "Oh, it shows on the bank statement." Yeah, they don't accept that. So I don't want to talk about this too in depth. VA pension and aid and attendance. We just thought it was important to put this on so that you guys know that aid and attendance might be available to your ward to help pay for long-term care costs. So it pays benefits in addition to a veteran's basic pension. For veteran spouses, for surviving spouses, they have service requirements, disability requirements, and asset and income limitations. And the service requirements for aid and attendance are an honorable discharge from a branch of the armed forces. And I did see something recently. I was on their website and I saw something. If somebody had a dishonorable discharge, there is a way to appeal that or change that designation for the purposes of having aid and attendance.
Was it dishonorable?
Other than honorable, sorry.
Other than.
No,
yeah, I don't
other than
dis.
Yeah, other than honorable designation.
Yeah.
That can be changed. So there's an application on the VA website to do that. So if somebody is a surviving spouse of a veteran, they have to have had 90 days of continuous military service and served at least one day during one of the following wartime periods. And World War I don't think there are a whole lot of folks still left that served in World War I, but still on the website. So, if they were in World War I, World War II, the Korean conflict, and interesting that they have two different periods for the Vietnam era or the Gulf War, and those are the dates there. But it's money that's available. If somebody is in an ALF and they are have low income and they had a spouse that served in the military, it's worth looking into getting aid and attendance. It is a pain, but there's a lot of paperwork. If they don't like the way you dotted your I, then they will send the paperwork back to you and you have to do something else. And make sure that you work with an accredited representative to prepare the application. The VA requires that. You can't just, anybody can't charge you to fill out an application. They have to be accredited through the VA in order to do that. And that's just somebody that's going to charge you money. You can have anybody help you.
And one little surprise about aid and attendance when I got started that I didn't understand. I worked so hard to get aid and attendance, which at the time was, I'm going to say roughly $1,800. It was a lot, and worked so hard to get it. And then the client ended up in a nursing home, and then it drops to $90. And man, that was a shot in the gut. All the work we did, and I don't know, maybe it doesn't matter anyway because at ICP they take the income, but dang, somehow it just bothered me. So if you've got someone who's already in a SNF, skilled nursing facility, and likely to be long-term care there, whether you go through all the work for aid and attendance, you need to really do the assessment as to whether that makes any sense.
Right. Okay, in order to be eligible for aid and attendance, you need to have at least one of these requirements. You need assistance performing your ADLs, or they must stay in bed or spend a large portion of the day in bed because of illness, or be a patient in a nursing home due to loss of mental or physical abilities, or their eyesight is limited. And there's another benefit called housebound benefits, but you can't have aid and attendance and housebound at the same time. And like I said, we just wanted to mention aid and attendance. If you need additional information, please call your local VA office because they are the experts on this. They can tell you with just probably a few questions whether or not this person, it would be worth your time to go through this process to get it, that there is money available if you know that that person served in the military or they have a spouse or ex-spouse or a deceased spouse that served in the military.
Well, divorces get way more complicated in aid and attendance. So if you're dealing with a widow who divorced her military husband, you're probably not going to get the aid and attendance for her. Divorce creates a much big bump in VA benefits for the recipient. Now, if the veteran gets divorced, that doesn't matter because he's not talking about his divorced girls, but if he's a veteran for himself, but if his wife, ex-wife, 2 or 3 ex-wives, it can get super difficult to get it when there's a divorce involved for the spouse.
And I just wanted to mention, if somebody is getting VA benefits and they're applying for Medicaid, request something. We call it the VA breakdown letter. That's what I've called it since I worked for Teresa. But what it does is, because aid and attendance, if they're getting aid and attendance, that is not countable by Medicaid. So that can make a huge difference in somebody's countable income for Medicaid purposes. And the VA breakdown letter shows what their survivor pension. If you look at this, it shows the basic pension is $895, and the aid and attendance is $536. So that's a big difference in what their countable income is. And all of the letters, we've had different people at the VA call this different things, and I haven't found a form number for this. But if you talk to someone at the VA, just tell them you need a breakdown of their benefits. If they are getting aid and attendance, you need that amount broken out, so that because you're filing for Medicaid, so that they know what type of letter to send you. And I've had somebody, but she talked to 5 different people. She had 5 different letters, and none of them was the correct letter.
Well, you know, as I'm sitting here looking at this, I'm also thinking this is actually a great idea for your accounting and your inventory, you know, in the guardianship world, if because you might have a gross number and they'd like to see how this might be really helpful to get it on every new case that has VA benefits, just so you're clear what bucket is this money being pulled from. I think it might be helpful, and I think it might be something that might make sense for accountings down the road, possibly.
So that puts us to the point where we have room for questions. And
all right, we have quite a few.
I can't see.
Yeah, I'll do the questions. So what I'm going to do is I'm going to work from the Q&A first. I know there's quite a few questions sitting in chat. I'll have to get to those second because that's a lot more digging for me. So let's start with Ted. If an autistic child of 22 is receiving SSI, would that child automatically qualify for iBudget waiver? As I thought the general rule was if you receive $1 of SSI, you qualify for Medicaid and waiver programs. Boy, I think you're mixing about 4 things, Ted. We're not focusing on APD here. We were just kind of bringing it up as a subject. APD is such a specialty that you guys may know Claudia. She often does presentations on APD to get somebody through this. Tracy, do you want to say anything about his question? Because I feel like it's really a mixed bag.
Yeah, if they're on SSI, they qualify for Medicaid. Since HCBS is a waiver program, and I don't know, let me just say for a minute, and I maybe not be explaining this appropriately, but Medicaid and ICP, QMB, those are entitlements. So if you meet the financial qualification and the medical qualification for being in a nursing home, you're entitled to apply for that and get it. Waiver is a separate bucket of money. So just because you have Medicaid doesn't entitle you to that bucket of money. Pretty much everybody that I'm aware of that has gotten on HC or any waiver program has to go through the channel to get on to be eligible for that bucket of money.
Yeah.
So it's not the regular state-funded bucket of money. It's a separate pot.
Okay. And so, Ted, we do know that you guys always want more APD information, and we have Claudia usually present once or twice a year, and I'm sure we will, and we get into the nitty-gritty of APD and SSI and iBudget, because that's its own little animal. So we're just going to leave that at that. All right, Barbara says, you said that the waiver program doesn't pay for ALF. I think there needs to be some misunderstanding. Do they pay any of the room and board? If so, how much? Okay, so you want to answer that, Tracy?
No, they do not pay room and board. The resident, the patient pays the room and board. What the HCBS, the waiver pays for is assistive services. It pays for medication management. It pays for them to change the person, to assist them with whatever they need. It does not pay room and board ever. So that's why the amount is so low, is because they're paying for the assistive services.
And to be clear, because this keeps coming up, Medicaid does pay under ICP the entire skilled nursing facility bill minus the ward's income minus their personal needs allowance. That's for ICP. In the ALF world, it's very different. We've had people talking about the fact that the guardian may be using the PNA, the personal needs allowance money of the ward, to be able to pay enough for the ALF bill to be covered. That is a reality. And there seems to be, just as to bring this to your attention, there seems to be some issues going on right now with Social Security audits about this. And Tracy found out that Florida is one of only 5 states that doesn't set the number for the ALF bill in a waiver situation.
There's no
So-
cap.
For the cap. So it may be that the auditors are national auditors versus like state of Florida auditors. This a bunch of guardians have been talking about this. It's been on our peer group. We're having conversation about trying to get a straight answer. So just let that understand that that may be a problem. Okay, so the next.
Can I just say that,
Go ahead.
Teresa, let me just say that I think people get very confused with, they consider all long-term care the same. The SNF and ALF, two different things. One is a patient responsibility to the facility, and one is room and board. And so that those are two different things. So make
Very
sure that
different.
you're clear on that. Two
Very
different
different.
things.
Yeah. Okay. So Patricia says, does the ward have to be present during the Medicaid HCB interview? I think you're talking about when they come off the wait list interview. Denise.
The CARES assessment.
The CARES assessment. Denise, does the ward have to be there, or can just the guardian do it?
For the initial interview, if you're calling on behalf of that ward, if the ward is not able to answer questions, then that's fine. They don't have to be there. Because you want to make sure that the person can actually answer questions. But the
for the
CARES
second-
interview,
Yeah.
yeah, when the person, I would suggest yes. Because then the CARES person can see what's going on with
And
that
so what
person.
happens if like the ward's in the hospital or something's going on? Can we get them to meet us there, or does it have to be in the residential environment?
It depends. When I was doing it before, CARES would not go to a hospital.
Oh, okay.
They would the person had to be at the facility or at home or whatever.
Okay.
That
All right.
they would postpone it until the person was back.
Okay.
Yeah.
All right. Barbara says,
I don't know if they do that now, but you know.
okay. All right. Barbara says, I thought it was 3 years of bank statement. Is it really only just 3 months? You want to address that, Tracy?
No, generally they want the 3 most current months. They can request back to, several years back. I think in doing this in 14, 15 years of doing this, I've had them request 6 months back once. But generally 3 months is enough for them to get the information that they need.
I think the only time they start requesting prior years is when they suspect gifting or they suspect some kind of money shenanigans that was not reported on the application. I think that's about the only time that happens. Okay, Barbara's next question is, I'm sorry, Teresa Brock. I have been told recently that facilities are charging different plan amounts because each pays different. So that's kind of, yes, true, because here's the deal. If you're in Humana, in an ALF environment, and they're giving the facility, well, for that particular client, $1,320, and the facilities bill is $3,100, the income that ward has to have is the difference between what's coming in from Medicaid and what needs to happen to pay the facility bill. So they all charge different. They charge different based on all kinds of things, including which program. So Patricia says that is the initial phone interview. Patricia, I'm not following your question there. All right. Marilyn says.
That was from her previous question.
From a previous question, you figure what's it mean?
Yeah.
Okay. All right. Marilyn says dental care is very challenging for persons with disabilities. Is there a list available? Tracy, there was only 2 providers, right, that you found of the dental?
Right.
Yeah, there's not much of a list.
That's according to the, yeah.
Not much of a list. Okay, Sharon says, just want to confirm someone on home and community base with long-term care comprehensive plan and Medicare. Do they need a plan D? Oh, that's a great question. Tracy?
Okay, I didn't touch on this because it gets very complicated. If someone has, if they have straight Medicare, they do not need a separate Part D plan. The MMA covers that. If someone is on, the MMA is the Medicaid plan. So they have Medicare and the MMA to cover their medical needs, including pharmacy, and then they have the long-term care plan. if someone has a Medicare Advantage plan, that's different. The Medicare Advantage plan takes the place of Medicare, original Medicare, and it has to be a dual eligible Medicare Advantage plan, dual eligible, in order for it to cover the Medicare portion, the Medicaid portion, and they need to make sure that Part D is included in that too, because once you have a Medicare Advantage plan and they have get on Medicaid, then the MMA drops off. They can't have both of them. So they'll get a letter that says they're disenrolled from in fact, I had a call yesterday from someone, they were disenrolled from the MMA plan, portion of the long-term care plan. And she was concerned. And I said, did you just sign up for a Medicare Advantage plan? And she said, yes. And I said, is it dual eligible? Yes. And if you sign somebody up for a Medicare Advantage plan or they have one, you just need to make sure that Part D is included in that coverage as well.
And so this comes back to the whole planning of whether or not you keep these, if in guardianship, whether you keep these wards on Advantage plans at all. What is the reason to do it? Problems does it solve? If you go to traditional or original Medicare and Medicaid versus Advantage plan and Medicaid, think about whether there's enough benefit to you, to the ward, like the limitation of networks in Advantage plans and skilled nursing facilities is a huge problem. And there's a rare occasion in my mind when it makes sense for a ward to stay on an Advantage plan and not go back to traditional or original Medicare. So keep getting yourself educated on how traditional Medicare works versus Advantage Medicare works, because one of the big problems is you've got a client in the hospital and they need to rehab in a nursing home under rehab benefits. If you're using Medicare, original traditional Medicare, you're rarely stuck with no choices. If you're in an Advantage plan, that's a network system. And that means only the skilled nursing facilities will do rehab for your ward if they're in that network. I don't like guardianships being limited to networks because you already have enough limitations. Rarely do we keep someone on an Advantage plan. So really get educated on the difference between Advantage plans and original Medicare. Talk to other guardians about what their experiences are, because we often find that under traditional Medicare, someone hits the nursing home door, they have no problem getting the full coverage of the days. But if they're on an Advantage plan, suddenly it seems like for the same condition, the window gets shorter. It's not supposed to be that way. Advantage and original Medicare are supposed to act exactly the same, but in the real world, they often don't. So talk to other people about why you choose that. Okay, let's see. Next question. How are we doing on time? 12:24. All right. Do you have to use, in this case, the $199 overage for a dental plan, or can the ward decline dental and keep that?
You can decline dental, but you cannot keep the $199, because once they know, the dental plan knows that you have disenrolled, they will let DCF know, and that patient responsibility will go back up. So don't try.
Oh, that's what she's asking. Okay, I wasn't following the question. Okay, all right. Teresa Brock, who chooses the plan the ward may be placed in? This is so important that you hear that it is you. You will have a client in the hospital and they're sending them home with some kind of home health. And they say, oh, we're picking Advent Home Health. No, you're not. I'm picking the provider. Always, always. And if it gets picked for you and you don't like that choice, change it. You absolutely, if it's a plenary guardian of person or property, you have the right to choose it. All right. Katina's asking a question that I'm not sure I understand. Have you seen a situation where someone is under hospice in LTC and has LTC Medicaid, and the person is told not to pay the facility as much and to pay hospice instead? Tracy, I'm not following that at all.
Yeah, I'm not sure exactly what they're talking about.
You're talking about someone
That
in a SNF.
I would say
I'm not aware that you would ever pay hospice, ever. Why would that be?
I I can't speak on that because I'm not
Yeah,
familiar
me
with
either.
that
Katina,
type
I
of
don't know.
situation.
That sounds like some fishy business. All right, Teresa Brock. If a veteran is 100% disabled, would they still be eligible for aid and attendance? That's a diaper question, and it depends. It depends on how much money. So you meet with the VA service officer and you figure that out. It's not a question we can answer here, one for individually or also for the whole program. Next question, Olivia. So are you saying aid and attendance for SNF is only $90 a month? Yeah, I'm saying, and it makes me sick. So you go through all that work to get them aid and attendance while they're at home or they're in an ALF or somewhere else, and then they have to go to a SNF for higher level of care. Eventually, on Medicaid, eventually VA will drop it down to 90. So when that actually happens, it can be a bit of a dicey problem because sometimes it takes the VA a couple of months to stop that money, and it can actually create a Medicaid problem. So be very aware if you're moving a veteran on aid and attendance into a skilled nursing facility for long-term stay under Medicaid, under ICP. Be careful because you can end up with an overage and the VA saying we want that money back, but you can't hold that money because you will be over income or over asset. So be really careful. That transition is dicey. Okay. Ward gets spousal benefit from VA. She has her own income as well. She lives in an ALF. Is she eligible for aid and attendance? Is there an income limit? So the answer is yes, yes, and yes. A, she may be eligible. Depends. There's diapers involved. She has both expenses that the VA accepts for aid and attendance. And then when you said she gets spousal benefits from the VA, that can be all kinds. It can be retirement. It can be all kinds. So these are questions you have to ask of a service officer in front of them with all the file in specific, very specific to that unique client, because it's really different per client. Okay, Katora, can you please explain how UMed works? If a long-term care facility gets less something money withheld for held for outside bills, can they kick you out, and how much can they withhold for outside bills? Okay, I think I know what you're asking, because I always ask this about if an ALF, if a SNF has 3 months of bills, we're going to say $9,000 that they didn't get paid for, and then through UMed we're reducing the patient responsibility that month and however many months it takes to pay back this 9,000. I always struggle whether the business office manager in a skilled nursing facility actually will bother, which will actually net them more money. Tracy, can you kind of like talk about that?
Well, if the nursing home is doing the Medicaid application, it's not in their benefit to submit a UMed because they would get less money.
That's what I thought.
They are bound to uphold what DCF says. So if DCF drops their patient responsibility down to $10 a month, that's what they have to take. A UMed does not go on forever. Usually it's broken out, the amount is broken out either over 6 months or a year in order for them to pay that money back. So the facility has to, I don't know if there's a law that says they can't kick them out, but they have to abide by that. And we've not seen anybody that's had an issue because DCF sets what the patient responsibility is in a SNF.
Now, honestly, what I would do most of the time is just go meet with the business office manager. And I'm like, look, you got $9,000 owed, but we're going to knock down the patient responsibility every month. So are you gaining anything? And let them kind of say, yeah, we do want the UMed or we don't. I don't know that we have an obligation. Now, we do have an obligation as guardians to get the ward's bills paid. So that might be where you talk to your attorney about whether you need to do UMed or you can just ignore it because you can't pay the bill. So that's a question for your attorney. All right. Anthony, can you change from one managed plan to another anytime, or is there an enrollment period? Great question.
You have 120 days to change the plan. Once you change the plan for the year, you cannot change it again until the open enrollment, unless there is a certain circumstance. There's a list of circumstances on the, I forget what they call it, but it's on the ACA website. If somebody, say that the assisted living facility, you change assisted living facilities and you have Sunshine, and your new assisted living facility does not accept Sunshine, that would be an exception. So you would be allowed to change the plan. If they are not responsive to the person's needs, if they are ignoring them or something like that, the plan is not working out for your ward, then you can file for an exception and change the plan if you've already changed it once. So there are, you can change at least once, and then there are exceptions.
Okay. Tina has a funny comment. She says, I'm wondering if the business office is wrong, and that's the problem. I think she was referring back to either the hospice question. So, keep in mind how often a business office manager, staff member in nursing home changes. It's really often. And so they don't necessarily have current or well-trained information. That happens all the time. All right, so I'm going to pop through the questions in the chat for a few minutes. I think I've got all the questions caught up in the Q&A. So this is more of a comment. Sharon, who, as you all know, is with Aged, says, for anyone that has questions about qualifying for Medicaid when over income or over asset with a pooled trust, reach out to Sharon. That's what Aged does. They help you with your clients who are over income or over asset or both, and Aged is really good at it. And in the chat is Sharon's email and the phone number for Aged. All right, so the next question was, hold on, these are a little hard for me to find. I apologize. Is the website for APD apdcares.org? Is that the right one? For some reason, that sounds really weird to me. Okay. All right. Next question. Sorry, I apologize. It's very hard for me. Oh, the tech question. Everybody's asking, if you don't attend all 4 of these, can you get actual credits? Yes, but you have to do all 4. Kate has it set up. They're all recorded. At the end of the 4 sessions, you'll get all the slides, and then you'll have to catch any that you're missing. If you're missing any, you have to get them to get the full credits. All right. Let's see here. I'm so sorry. This is really hard for me to find questions. Okay. Will CARES notify when they will be going out to see that person in person? So Denise, how does that work? I mean, are they calling? Are they sending a letter? What should we expect as a notification of when the in-person meeting is going to happen?
The CARES person will call to let you know when they're coming out.
Okay.
As long as they have the correct information from DCF.
Okay. All right. So when I get the packet, including a blank 3008 from Elder Options, when I utilize that route, they will highlight the areas that must be filled out. Oh, that's interesting. Okay. All right.
Yeah, we used to do that too.
Okay. Yeah, you want to try to make sure they don't miss anything. Okay.
Right.
All right. I'm so sorry, guys. It's much harder for me to do this. Okay. Rihanna, maybe, says, in that case, ask a VA for other eligibilities, including help with coverage of costs of veterans approved SNFs, especially if they do not qualify for Medicaid. Right. So the VA is the VA. You have to go to them to get all your questions answered. Okay. All right. I think that's all the questions in the chat. Let me double check the Q&A. Okay. Another question in Q&A says, can you give Cliff Notes? Why do I need a home use waiver for a specific ward? Okay, sure. So here's why. Let's take an average client. You became the guardian. She has a home. It's not appropriate for her to live alone. She doesn't have enough money. She has to sell the house. So maybe she gets net $40,000 from the sale of the house, and she's got an income of, let's say, $2,500. If she goes into an assisted living for care, she's not likely to find $2,500 monthly bill. It's going to be north of $3,000. It could be north of $6,000. So if you don't get involved in the home and community-based waiver program to eventually help start paying for part of her services inside the ALF, she will run out of money. Does that help, Allison? That's one common example. All right, going back into, okay. All right, I'm going into chat. She's mentioned, I'm so sorry, I don't know how to pronounce your name, honey, Rihanna. She is saying she's clapping because elderly folks get talked into Advantage plans and they're not actually a good fit for them. That is a real problem, always has been. And as a guardian, it was very rare a case where I would keep a ward in an Advantage plan and not get them on traditional Medicare if they'd qualify for Medicaid. But remember, you got a 20% problem over here. So taking them off of the Advantage plan and putting them on traditional Medicare leaves a 20% problem. They have to be qualified for Medicaid, the right Medicaid, to handle that 20%. So you can't just pop them off Advantage, put them on traditional Medicare without a plan for the 20%. Okay. All right. Now we've got lots of folks saying, thank you. Wonderful information. Very helpful. And I'm looking, I don't see any more questions. Oh my goodness, look, it's 12:37. We are almost on time. Okay, so some more thank you, such wonderful information. First of all, we're so glad you guys are here because you're doing the hard work, and understanding all these benefits is a constant problem. Honestly, I will tell people it took me quite a few years in the beginning as a guardian to understand Medicare, Medicaid, APD, Social Security, SSDI, SSI, OSS. Honestly, it's not easy, and you have to keep learning it. And it's not changing a lot, but it changes enough. And one of the biggest problems we have is names. So we kind of say the word waiver, which causes trouble because it's kind of like saying ice cream. What waiver? And so you try to use the proper name. One of the things that we laughed about when we were doing these slides is we started using our slang names on the slides because we're so used to doing it. And we tried to not do that because it's not helpful when your own words are not actually what it is called, even though the caseworker might call it the slang name. So try to get out of the habit of using slang names for these programs because it's just confusing. Adria says, this is helping me so much for my job and my 90-year-old grandmother, who I am the primary caregiver for. You know, it's so funny. Almost everyone you come across in this world is dealing with a family member with these very issues. It doesn't mean it's a guardianship. They're just dealing with it and they need help. All right, some more thank yous. Okay. Tracy, what else would you like to talk about? Is there anything else you want to bring up?
No, we can let these good folks go, but just the next class is on the 11th. So that's next week. And we're going to talk about ICP and hopefully tie up any little questions that people have. And absolutely, if you have questions that you want answered, then send it to me in an email, send it to Teresa, and we will try to get your questions answered.
Tracy, we've got somebody asking what date and time is it? Can we put that up on the screen, the little list of them? Allison says, it's so comforting to hear you say that this is hard. It is really hard. And the problem is, as a guardian, you need the education. You can't take your chance of, that doesn't show, oh, it does show the date, the 12th. Okay, good. You know, you can't not make good decisions for the benefits of your ward. And one of the things to get comfortable with emotionally is plan for the worst and hope for the best. So, for example, when I've got a guardianship and we're getting somewhere near the $100,000 rate amount of money, I'm getting nervous because something could happen and that money could evaporate. If they're in a nursing home under private pay for 6 months, 8 months, that money is gone. So when I have like my own litmus test of about $100,000, and if a client is getting close to $100,000, my attorney and I are looking at whether we should be doing Medicaid, even if they have a big juicy income of $5,000, even if we think it's going to be okay. What if it's not? So plan for the not. Marilyn is saying, are the handouts available? No, they will be, but we don't give the handouts to the last session. So it'll be after February 12th when all the recordings are done and the handouts go out to people who've taken all 4. Now, Kate works the details of this, so I want to be careful what I say. I actually don't know if she just sends them out automatically or not. Kate, if you're still on the call with us, if you want to put a little what you're going to do automatically after the 12th. Okay, so thank you guys all. It is 12:40, so that's really kind of not bad. Thanks everybody for coming. We got one more, come again, because this will all kind of like come back together with all the big pieces we're adding together. All right, everybody, see you again on the 12th at 11 a.m. Same thing, Zoom, and bring your questions. Thank you for all the work, Tracy and Denise. Thank you guys so much for putting all this together.